Welcome to today's conference, Palliative Care Networking Group Conference, Advanced Care Planning when a Patient has Dementia. My name is Cheryl, and I will be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. I would now like to turn the call over to your host, Janelle Shearer. Please begin.
Hi, everybody. This is Janelle from Stratus Health. We are the Minnesota organization that is part of the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to the Rural Palliative Care Networking Group today. This is a group that meets 3 times a year virtually to network and learn from those interested in providing palliative care services or end-of-life services, especially to those in the rural areas. People from all disciplines and settings are welcome to participate. So just before we get going, we'd like to know what type of organizations are on the phone today or the webinar today. So in the chat box, which is on the right side of your screen, would you please just put whether you're a home health agency, nursing home, hospital, or whatever your organization type is, and the state you're coming from that you are at, because we have folks from a variety of states. Our education session today is called Advanced Care Planning when a Patient has Dementia. This is a webinar 1 of a 3-part webinar series on advanced care planning that we'll be doing in 2017. I'm pleased to have Karen Peterson, the Executive Director of Honoring Choices Minnesota, here with me today as our presenter. Before I introduce Karen, I'll mention that all lines are muted during the webinar. However, afterwards, we will have the Q&A time. So just jot down any questions that you have as the presentation goes. You can also use the chat feature anytime during the presentation, and we'll be keeping track of those and bring those up at the end. So now I'll introduce Karen. You can see her on the screen there. Karen is the Executive Director of Honoring Choices Minnesota, a public health initiative of the Twin Cities Medical Society, which focuses on bringing advanced care planning to all parts of our state. Karen, who received her BSN from the University of Minnesota School of Nursing, is a frequent speaker on this topic and enjoys presenting to diverse groups about the importance of understanding advanced care planning so that every Minnesotan can share their goals and values about end-of-life experiences. Thank you, Karen, for presenting today, and I'll turn this over to you.
Hello, everyone, and thank you for letting me be your speaker today. I have to admit this is the first time I've done a webinar like this, so I'm hoping that everything goes smoothly and that you're patient with me. As Janelle said, today we're going to talk about advanced care planning and issues of dementia. And the objectives for today include talking about the difference between capacity and competency, understanding what types of decisions can be made when you're working with a patient or a client who has dementia or who has memory issues of some sort. And then I also want to touch a little bit on how to work with people who have not been experiencing memory issues yet and don't have a diagnosis, but who anticipate or are worried that they're going to. We get a lot of questions from people saying, what do I write in my directive to accommodate the changes that I know are coming? So we'll spend a little bit of time on that as well. Sorry, we're having a little technical difficulty as I learn how to advance the slides. I'm using the mouse with my left hand, and it's causing confusion. So before we start into any of those objectives, though, I want to just give a basic overview of advanced care planning just to make sure we're all on the same page. Now, looking at the list of attendees, I'm recognizing quite a few of your names, so I know for some of you this is going to be review, but for some of you it might have some new information. Basically, advanced care planning at its broadest comes down to 3 basic questions. The first question, of course, is who are you going to choose to speak for yourself, to speak for you when you cannot speak for yourself? And a lot of people think that they can put off this decision until somebody is older or until they have a diagnosis, which is likely Really, it's important for any one of us, especially living in the upper Midwest where people have skiing accidents and hockey incidents, and, you just never know what tomorrow's going to bring. And so really choosing the person who is going to be able to make those decisions for you is important for all of us. The second question focuses on life-sustaining measures. In other words, if your heart were to stop, what do you want the healthcare team to do? And for someone who's relatively young and relatively healthy, we ask them to consider, if you were to have a sudden heart attack or get hit by a bus or struck by lightning, what would you want the healthcare team to do? But we also ask people to imagine the future when they're either elderly and frail, or if they should have a chronic diagnosis, would their priorities change? And then finally, in your advanced care plan, we really encourage people to share personal information. We want people to share what types of personal, spiritual, and cultural considerations they would like their caregivers to know about, in order to make sure that when the end of life is coming near, those things can be honored and respected. And I've seen healthcare workers, nurses, social workers, chaplains bend over backwards to accommodate people's values and wishes, as long as they know what they are. And so it's really important to have that. Of course, after a lot of discussion has happened on those 3 points, we do encourage people to write it down onto a directive and make it legal. We encourage people to share copies with all who are going to be involved, both within the healthcare world and within their personal lives. And then, of course, to revisit it, because life changes happen to us all, priorities change, wishes change, and we want to make sure that the directive that's on file is the most current and up-to-date one. So that's a general overview of advanced care planning. Now we're going to look at advanced care planning and dementia and what changes, what's different. Well, basically, it's still those same 3 questions, except you're looking at everything through the lens of making sure that you understand the differences in the definitions of capacity and competency. There's a heightened importance about being detailed and inclusive, making sure that everyone is on the same page, and making sure that you're really answering questions in depth when possible. When working with a person who has dementia, you want to be sure that you're using the best tools that are appropriate for the situation, and that the person who is facilitating the discussion is specially trained, both in the area of dementia but also in the area of advanced care planning. And then finally, it's critical to be aware that timing is everything. If you work with patients who have dementia or any type of memory issue, you know that there are good days and there are bad days. And so you want to look for windows of opportunity, but also timing in the bigger picture. If you expect or suspect that dementia may be in your future, then clearly it's even more important to start your advanced care planning discussions and get your health care written early before the diagnosis arrives and before the changes come into your life. So I want to look real quickly at the Minnesota laws about advanced care planning. In order to be a legal document in Minnesota, and I don't know if we have anybody on the line from Michigan or Wisconsin, I would encourage you to be aware of what your state laws are. But for today, since most people are here from Minnesota, we'll focus on the Minnesota laws. To be legal, it has to be in writing. A lot of people talk about making a video or an audio recording as their directive. That's fine, and it can certainly be helpful, but it's not going to be legal or legally recognized. It has to be dated. It has to have the principal's name and signature if possible. And then you look at number 4. It has to be executed by a principal with capacity. And so let's look a little deeper at what does that mean. According to Minnesota law, which I'm trying to click, there we go, a principal with capacity is in the judgment of the principal's attending physician, A person is declared not to have capacity if the physician deems that they do not have the ability to understand significant benefits, risks, and alternatives to proposed health care and to make and communicate a health care decision. So capacity is something that's medically determined. Catching up with my notes here. And it differs from competency, which is a legal definition. Capacity can vary day to day. It can vary hour to hour. The agent is called in when the patient or the principal is deemed to lack capacity, but it can be very fluid and very flexible. And so that goes back to having the person who is coordinating these conversations to be somebody who knows what they're doing, has a relationship with the patient, and can recognize the movement in and out of capacity. Competency, on the other hand, is a legal definition. It's assigned by the court. In Minnesota, at least, it's very, very difficult to be declared incompetent because it is all-encompassing. Once you are declared incompetent, a guardian is assigned by the state, and it is not something that you come in and out of based on the day or circumstances. So with dementia and advanced care planning, capacity is the concern. So now let's talk about dementia and the diagnosis of dementia. We know, unfortunately, through research, that a diagnosis, an actual diagnosis of a type of dementia, any type of dementia, is oftentimes difficult to have documented. We know from research done by the Alzheimer's Association that over 50% of physicians in this country admit that on occasion they may have a patient with some form of dementia, but they don't formally diagnose it or tell the patient. So we know that this is a huge issue because oftentimes it takes that label, that definitive diagnosis, in order for different services to be offered and for considerations to be made. We also know that for many physicians, it's not something that gets well explained because, unfortunately, in many situations, they feel like it's not reversible, it's not curable, so we don't really have to talk about it. Well, obviously, that's not what family members and patients want to hear. An early diagnosis can allow time for more quality conversations to occur, for more learning to happen, for more planning, and for more talking. So we really, that's beyond the scope of Honoring Choices, but we definitely support the work of the Alzheimer's Association in trying to increase physician education and reactions to dementia diagnoses. One of the things, looking at capacity, that's critical to remember is that you can't say somebody doesn't have capacity simply because you don't think the decision they're making is the right one. This is sometimes a challenge for family members. You can't look at the decision, you have to look at the logic that was used to get to the decision. They may choose something that their family doesn't agree with or that you as their healthcare provider doesn't think is the best choice given their circumstances. And it may be tempting to say, oh, that person didn't have capacity to make that decision. But you have to, it's up to the healthcare provider, the practitioner working with the patient, to analyze the process that was used to reach that decision. And that's where you determine if the person has capacity. If they're basing their decision on realistic data, a real understanding of the situation. And that, again, comes back to the need for people who are trained to be doing these types of conversations. If you have a patient who makes a decision or maybe makes a series of decisions, though, that you think are a little suspect and no diagnosis has been made, there are tools that are available that you can use to help get an indication of whether or not a patient needs to be assessed for a memory issue diagnosis. One of the most commonly used and one of the best available tools is called the MiniCog. You can find it at mini-cog.com. It's a simple test, a 3-step test that can be administered and can be immediately evaluated. And if a patient or a client does not do well on the mini-cog, then you have some evidence to use to ask a physician to look into it and possibly get a neurology consult. Now to switch gears for just a minute, let's talk about that other group that I mentioned earlier. I said we get a lot of questions at Honoring Choices about what if I think I'm going to develop dementia? We know that for a large number of people, dementia is scarier than death. And so people are very concerned about this, especially if there's a family history. Now, currently, there's no definitively known single causes or cures for dementia, although research, I think at least once a week I get something in my email inbox from new research and new studies that are being done that are promising. We do know risk factors, though. Obviously, the number one risk factor is age. The older you get, the more likely it is. Gender plays a role. Women are more likely than men. Ethnicity plays a role. Your general health, there is definitely a genetic factor, and your lifestyle choices. For example, things like smoking, exercise, diet. All of those things can affect the likelihood of whether or not you will potentially develop dementia in the future. So if you think you are at risk, if you look at your family situation, your medical situation, your general health, and your lifestyle, what can you do? Well, the first thing we say is change what you can. If you can make some lifestyle changes, research is showing us that even if you stop smoking at age 60, you're still going to reap benefits pretty quickly. You can increase exercise. You can change your diet. You can do different things, and this is what we advise people if they're worried about developing dementia. But when it comes to advanced care planning, what you really need to do is choose a tenacious and fearless agent. And those adjectives are chosen very, very carefully. Because really, your agent is going to be the one who is fighting for you once you have dementia and once you are deemed to lack capacity to make decisions for yourself. So you need to choose someone who is definitely going to be strong enough to stand up, because family will often disagree. Even if you have a healthcare directive written down, family members will often disagree what happens once capacity is gone, because there's a lot of emotional and ethical issues that will come up, especially if a person is in generally good physical health and lives for a long time with dementia. The agent's job is a stressful one, so the person needs to be strong. They need to be willing to take on family members, but also healthcare workers. You need to have many, many discussions with that person so that they are truly clear about your intentions, your values, and your wishes. Remember at the very beginning I said you need to be very detailed in your advanced care planning. If dementia is in the picture, you need to clearly outline in writing and then also follow up with the discussions about what is and what is not acceptable for you. Then you need to follow the legal statutes of your state. One of the questions that frequently comes up in this regard in talking about this exact situation is the right to physician assist in dying, or physician aid in dying. In Minnesota, clearly that is not permitted legally. As time goes by, laws may change. So your agent needs to be very aware of what the laws are, what's regulated, what's acceptable, what's not, and know how your wishes are going to fit into what the legal requirements and legal limitations of your resident state is. And then finally, and again, this is an argument for doing this early, you need to talk with everybody who's going to be involved in the care. other people who are not your agent. You need to explain things. You need to clarify things as much as you possibly can, because the complicated arguments that can come later, if you can head any of them off at the pass, if you can help people understand what your agent is going to be doing and why, it will allow other people in your family to support your agent. When we look at resources that are available, I said early on it was important to have the right person doing these discussions, but it was also important to look for the right tools. Alzheimer's Association, ALZ.org, has a lot of information, a lot of tools on both their national site, but they also give you a community resource finder so you can find out what's available in your area. I strongly encourage you, if you never have, to take some time exploring these websites. Explore the links, the documents, the tools that they offer. And in Minnesota, we are lucky to have Act on Alzheimer's as a Minnesota-focused tool base. And the work that Act on Alzheimer's has done in creating dementia-friendly communities, in training healthcare professionals as well as community leaders and community members about working with people with memory issues is outstanding. And again, if you have not ever taken time to explore them, I urge you to do so. You may want to use some of their tools to do employee in-services with your coworkers, or to have resources available for family members. There's a lot out there, and it's very, very good. When I started doing research on working with people who have a diagnosis or a suspected diagnosis of dementia and advanced care planning, I reached out to a number of people who are actively working in this field, and I asked them to identify what some of the barriers that they see in their day-to-day work. I said one of the biggest issues is that dementia remains so poorly understood. And part of that ties back to what I said earlier about physicians not taking the time to educate patients and their family members, diagnoses coming too late to be helpful. We also know that advanced care planning itself can be very complex and very time-consuming. It's not something that you can sit down and quickly do in a half an hour and then be done. It's something that takes a lot of conversations to do well. It may take some visits with doctors, with face leaders, with other family members to discuss different aspects and answer questions. So it can take some time. And with memory issues, time is not always available. We frequently hear specifically about advanced care planning that maybe you talk to an Alzheimer's advocacy group and they say, oh yeah, go do advanced care planning, but then they don't give anything more than that. So there's still a confusion factor for people who are working with advocacy groups sometimes. I know that there are some advocacy groups that are very good about this one topic, but it's still a work in progress. Someone who's trained to be an advanced care planning facilitator may not be trained to work with people with dementia and vice versa. So there is the training. And then finally, there's the chicken or the egg question that I hear. A lot of times, I'm told there are clinicians who will say, oh, you don't need to worry about that yet because you haven't been diagnosed with dementia. On the other hand, once you're diagnosed with dementia, it may be too late. If you're familiar with the Conversation Project, which was started by Ellen Goodman, she started it because her mother had dementia. And they recognized that she had memory issues, and they had talked about a lot of things, but they had never talked about advanced care planning. And the day Ellen Goodman realized they hadn't talked about it was the day that her mother had crossed that line and was no longer able to talk about it. So how do you make advanced care planning more friendly for working with people with dementia? Well, we've alluded several times now to timing is everything. I asked a physician early on in this journey if advanced care planning and people with dementia was an issue. And his rather flip response was, oh, no, it's not a problem at all. Just do what they have before the diagnosis sets in.
And I thought, well, okay, therein lies part of the problem because we don't know. We don't know when that tipping point is going to come. So honoring choices is really working, and I encourage you to work in your communities to really raise community awareness for all people, regardless of their age, regardless of the expectation of whether or not they're going to get dementia, because that way, if they do, they will have already started. The second thing to remember is that you need the right person for the job. The person who's going to do advanced care planning with patients and clients that do have dementia needs to know both topics well. There needs to be training available. The third thing that you can do, and I really like this little icon, it's a pair of shorts, because you got to keep it short. In talking with people who have diagnoses of forms of dementia, I have heard that oftentimes people will think, oh, if I'm talking to someone with dementia, I need to use really basic words and simple sentences. And the response I hear over and over again, it's not necessarily the level of the words being used, it's the length of the sentences. That a person can understand a complex concept as long as the sentence doesn't take too long to explain it. And the tip that was given was if you have to take a breath in the middle of your sentence to finish it, that sentence is too long. By the time you get to the end of the sentence, the person may have forgotten what you said at the beginning of the sentence, even if they understood it at the beginning. So you want to keep your sentences short, you want to get right to the point, and depending on the individual's window of opportunity, like I said earlier, people with dementia have good days and bad days, and sometimes you may only get a half an hour or an hour or two to talk, and so you want to make sure that you're jumping right in and getting to the meat of the topic pretty quickly, not engaged in a lot of small talk because you may run out of time. And then finally, you want to have a toolkit. You want to have things like the mini-cog available that we talked about earlier, so that you have resources and tools that are going to work for your situation, your workplace, and your clients. Going back to training your people, we do offer advanced care planning facilitator training that I know several of you who are participating in today's call have taken advantage of. In fact, I think there are a few of you on this call who are instructors. We have 3 coming up that anyone is welcome to. 1 in Northfield, 1 in Crosby, and 1 in Minneapolis. And we can bring the training to you. This is something that we've just started doing, and we're finding communities are very excited that they can have someone come in and train healthcare workers as well as community members on how to do advanced care planning and do it well. Another tool that we highly recommend when you're working with patients and clients that have memory issues is the Go Wish card deck. And this is something that's available online. This is a deck of cards that is loaded with a number of value statements. And when working with a person with dementia, you may want to go through and remove some of the cards. But basically, you have them read them, and then you have them put them in piles, things that are important, things that are less important, or things that are not important at all. And I have a couple of examples up here of things. And that can tell you a lot about a patient and what they want. And even if they can't necessarily give you information on medical treatments, they can talk about what's important to them, and you can get insight into what makes life worth living. Finally, I highly recommend using a shortened form of a healthcare directive. Now, our standard healthcare directive, which is widely used, or variations of it are used throughout the state, is 8 pages long. And that's usually, or sometimes can be, too long and too complex for a person who is starting to have memory issues. On the other hand, the short form basically has 2 questions on it. The first question is naming your agent. So if you have a person who is confused or does have memory issues, but you can ask them a question as simple as, if you were sick and we took you to the hospital and you couldn't talk to the doctor, who would you want the doctor to talk to?
It's a very simple way of phrasing who would you want to be your agent. And if you can be confident that the patient you're working with understands the question and names a person who they trust for the doctor to speak to, that qualifies as a legal naming of an agent. You write that down, you have this document witnessed, and you're done. The second question on the short form is an open-ended optional question, just in case there are any specific healthcare information or instructions that you want to be written down. But really the short form allows you to name an agent and then have that be legally filed in the EMR so that the patient has designated who they trust to make decisions on their behalf. Now, there are a number of resources available in addition to the Alzheimer's resources that I mentioned earlier. Our website, honoringchoices.org, has a lot of information on it. It is a work in progress. We just revised our website and we're still building it and adding on to it. So if you go to our website looking for something and you don't find it, please let us know and we will see if we can add it for you. Stratus Health also has a lot of different tools and services. And finally, the Minnesota Network of Hospice and Palliative Care has a lot of advanced care planning references too. Another thing to note is that we do have our directives available in 5 languages. In addition to English, they're available in Spanish, Hmong, Russian, and Somali. And we also have videos about what advanced care planning is in Spanish, Hmong, and Somali. So if you're working with any patients who speak those languages, you can refer them or share those resources with them. We also have educational materials which you can use freely in your site and share, and those too are available in all 5 languages. So that reaches the end of what I have prepared to say, but I'm sure that there will be questions and answers. You'll have questions. Hopefully I'll have answers. And so at this time, I encourage you can either type your questions in, or my understanding is in just a moment, Cheryl from the webinar company, or somebody will make it so that your phones will now work, or that your microphones will now work, so you can ask them verbally as well.
Yes, thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you are using a speakerphone, you may need to pick up your handset first before pressing any numbers. Once again, if you'd like to ask a question, please press star, then 1 on your touch-tone phone. Standing by for audio questions.
This is Janelle, and I see there's a comment on the chat which really resonated with me too, where it says, thanks for the hit by lightning example. You know, I really appreciated hearing about that, and even though we don't want to think about it, but like the hockey accidents, or, you know, there's car accidents, a lot of things that can happen to young people, which is a reason why everybody should have an advanced care directive in case you can't make the decision. So thanks for bringing that up. And while we're waiting for questions, I will just ask you a couple, Karen, if that's all right.
Sure.
So you know, it was great information, and I learned some new things. So thanks so much for coming and presenting about it. Have you heard of any examples of where patients or families were proactive like this with dementia? I think that's a newer concept too. I think it's just being proactive, because how many people get dementia? If you're over 85, I think it's about 50%, or it's quite high. You heard of any?
I don't have any specific case studies. I think this is something that's just becoming an issue, or becoming on people's awareness as the baby boomers age, and as more people are learning about advanced care planning, and learning more about dementia as well. I think public awareness in general on both of these topics is raising very quickly right now in our society in general. So I think this is still something that people are just starting to think about. I'm sure there are people who could share case studies. I don't have any personally. If any of you on the webinar have any case studies or examples that you'd be willing to email me. I would love to have that information to include in future presentations. One of the things that I kind of specifically shied away from it, but it's something that I think I'm going to go ahead and in Stratus language, face the elephant in the room, is the concept of voluntary stopping of eating and drinking. When people are thinking about their future, and like I said, we know that for many people the idea of having Alzheimer's is scarier than dying. And people say, if I get to that point, I want you to pull the plug. Well, lots of times there is not a plug to pull. And given that there is no physician aid in dying in our state, people say, okay, then I just don't want to eat. I want to refuse all food and water so that I'll die a somewhat natural death based on that. Well, the problem is that if someone has dementia and is relatively healthy physically, you'll still ask for food. You'll still feel hunger. And it becomes an ethical dilemma about, even if you have a healthcare directive that very clearly states, I do not want to be given any food or water, even if I'm asking for it, when I am deemed to be incapacitated. That's a very, very challenging wish for family members to follow. And so that goes back to the need for many, many discussions and conversations about this ahead of time. Now, I did check with a couple of attorneys, asking them about this specific situation. If a person with dementia does not have capacity to speak for themselves, prior to the diagnosis of dementia, had clearly outlined and discussed the want to have no food or water given, and yet now in an incapacitated state asks for food and eats eagerly when food is given. What's the legal issue there? And the answer I was given, that legally the directive will hold up in court, but ethically it is so challenging that it becomes a very, very messy, complicated situation. So I think this is something that we're going to learn more about over the next several years as people, like I said, people are becoming more and more aware of dementia and more aware of advanced care planning and the power that it gives you to have your voice, your current voice, have some say in the future situation. So again, if any of you run into that or have specific case studies involving a situation like that, I would really, really appreciate hearing about it. Now, I see there is a question here in the comment box. It says, in light of the fact that a video or auto-recorded healthcare directive is not accepted as a legal document, can this be transcribed? Absolutely. It can be transcribed and then signed and witnessed. The witnessing has to be two adults, neither of whom are the agent or the backup agent, one of whom can be a healthcare provider, but the other one must not be, or it can be notarized. Yeah, sometimes having a video or an audio can be really, really powerful if there's a disagreement amongst family members. If they can see their loved one's face or hear their loved one's voice, even if all they're doing is reading what's already written down, that can have an impact. That can be a very powerful tool. But you do have to realize that the written piece is the legal piece.
So I have a few other comments in the chat, and I'll have Jenna read those. She's managing our chat today.
We have one that said, love the suggestion of talking in short sentences for the dementia patient. And then the next one, wonderful presentation, good conceptual definitions and examples.
I'm curious, this is Janelle, I'm curious, is anyone on the line in an ACT on Alzheimer's community where you can either just share in the chat or call in on the phone and just say what is that like for your community? What have you seen that group do?
And once again, if you would like to ask a question or have a comment, please press star, then 1 on your touch-tone phone so your line can be opened. And our first question comes from Lori Steven. Please state your question or comment.
So my name is Lori Devin. I am a RN MSHO care coordinator in Ely, and we are our local volunteer agency, Northwoods Partners. We've actually, just in the last 4 or 5 months, we've started working to make Ely a dementia-friendly community. So we've just finished a bunch of interviews with community members, businesses, and entities, trying to figure out what our gaps are in the community first, and then what are going to be our actionable working goals, I guess you would say, to help increase the awareness. We haven't even, on another side of that, actually through our clinic, we were involved with a pilot program in bringing advanced care planning to Ely as a pilot project, just trying to increase the number of advanced directives that people have. So I guess Ely, we are really trying to make this, from both standpoints, an impact in our community.
Great. Thanks for sharing, Lori. Can you give us some of the tips that your clinic did in trying to get more advanced care plans completed?
So we have created, I guess we had Kathy Werzer, if anyone's familiar with her, from NPR. She came to Ely and she did what's called the convenings, which was part of her collaboration with Bruce Kramer, I believe his name was, as he was going through his process with ALS and eventually did pass away, just what that was like and what it was important to him during, through the change of his disease. So that brought a huge number of the community residents to the college for that, which really helped open up the dialogue about advanced care planning. Since that time, we've been holding just little informational things for group sessions, just talking about who's available to work with that with people. We have several community members that were trained, and then we have several volunteers through Northwoods Partners, too, that have been trained, and then a few nurses at the clinic that are available. So now what we're at is we have a telephone line that people can call in and put their name on, and from that list of designated trained facilitators, they can ask to have a facilitator meet with them and start the process. So that's kind of where we're at. That's kind of in the beginning stages as well.
That's fantastic. I know I saw the convenings, a little clip of it on the news. Actually, it's been on a number of times, but it was very good.
It was very good. Yeah, it's very moving, and it's very, people tend to think of this as being a very morbid conversation, when you talk about dying and end of life planning, but when you turn that around and start focusing on what's important to people and what they see their end being like, it just puts a whole different dynamic on it, and it helps them talk about it.
This is Karen again. Just another word about the convenings that Lori is talking about. There are 5 more events like this scheduled around the state coming up. You can find information on all of them on our website. There's a tab marked the convenings, but just quickly, in February, Kathy Werzer will be going to Laverne, Minnesota, to Southwest. In March, she'll be in Coon Rapids. April, St. Cloud, actually just outside of St. Cloud at St. John's University. In May, she'll be in Northfield, and in June, she'll be in Owatonna. So hopefully you can find one that's going to be close to you and experience it for yourself. I noticed there's another question in the comments about a homemade healthcare directive, and would that work? Absolutely. The way I always put it is we happen to think that our directive is really, really good, but there's nothing magical about it. As long as it's in writing that it lists an agent or lists health instructions. It does not have to have both. You don't have to have an agent for it to be legal. Of course, we encourage you to have one. But as long as it's in writing, has your name and the date, you sign it, and then it's properly witnessed, which is either two adult witnesses or notary, then yes, it could be written on a piece of scratch paper, and it would qualify as a legal healthcare directive as long as it meets those 5 points.
You have another comment.
Now, once again, if you have a question or a comment you'd like to share, please press star, then 1 on your touch-tone phone.
We have another comment in the chat that says, thank you for a wonderful presentation. Information enlightening and helpful as I worked with a loved one who has been diagnosed and lives from Lewy body dementia.
I'll also share that this is something that I clearly am very interested in professionally, but personally as well. My mother has Alzheimer's. And so when I am giving advice to people who look at their genetic makeup and are anticipating getting it, I look in the mirror sometimes. So I think for a lot of us who are in this field, there's often a dual purpose. Professionally to work with our patients and clients, but personally because we have a loved one in our families or in our close circles who have some form of dementia.
Cheryl, I'll have you give one more chance for phone questions, and then if not, we'll wrap up.
Okay. And once again, if you would like to ask a question or share a comment, please press star, then 1 on your touch-tone phone. And at this time, I show no further questions or comments in the queue.
All right, well, thank you. So we will conclude this educational session today. Thanks a lot, Karen, for coming over and speaking with us today. Our next webinar meeting of this group is Thursday, May 25th from 1 to 2 p.m. with a presentation from Karen called The Role of Pulse in Advanced Care Planning. And then the third webinar of this series is on September 14th, again, same time, 1 to 2, called Resolving Ethical Dilemmas in Advanced Care Planning. So we hope that you will participate in those. If you are someone involved in the coordination of care initiatives, the registration link is out on a monthly e-communication. For those in the Rural Palliative Care Networking Group, I will be sending you an email to register for those other two. Before you log out today, please complete the survey that will pop up on your screen. And once you've completed the evaluation, you will receive a certificate of completion. So please make sure that everyone on your team that has participated in the webinar today receives a copy of that. The session was recorded and will be available on the LSQIN website in about 2 weeks. Thank you all for participating and have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. At this time, you may now